one of the things that I get to do, which I really love to do, is my room derm multidisciplinary clinic with Stratos Christianakis. And we do that once a month. We do it at County in the mornings and at Keck in the afternoons. And it's just like an amazing clinical experience where I say I get CME basically monthly from it. But I think also really importantly, I think from a training perspective, I really enjoy it. Our residents participate in the room fellows as well. And then also from a patient delivery perspective, I think it's a really satisfying for the patient. So because of this interest, this clinical interest I have, certainly cutaneous manifestations of systemic disease is something that I love to think about and love to talk about. Next slide. And just also wanted to pause to say thank you to all of you. One of the things I love about working at USC is the ability to work with really great colleagues in other departments. And the Department of Internal Medicine has so many awesome people in it that I really love collaborating with and sharing patients with. So just, I would be remiss to not mention that as before I move on to the next slide. So today I'm just going to go through a format that's a little bit case-based, like kind of loosely case-based. And my goal is to try to highlight some common presentations within different medical subspecialties, and some of them are covered, but not all of them. I'm focusing on diagnostic recognition. So kind of focusing on like, if you guys were to see something in your clinic, something that might help you to like solidify what you think the diagnosis is, or to help you to know that it would be maybe a trigger to consider other things. I touched briefly on diagnostic on therapies as well, but not a whole lot on therapies. And then this is definitely not all encompassing. So Dr. No, who I'm indebted to for portions of this lecture, has like 200 slide decks about cutaneous manifestations of systemic disease. The reason I cut down on this is because I just think it's overwhelming. Like, I think it's hard to absorb it when there's that much going on. So definitely there's a lot of amazing things that happen on the skin as manifestations of systemic disease that I don't discuss today, but it's not because they're not cool. Let's move on to the next slide, please. And we can go quickly through it because I think it's my disclosure slide, which says no disclosures. Thanks so much, Brandon. I'm so sorry. And then to our cases, perfect. So this first case is a 30-year-old gentleman who had presented, who'd had a diffuse rash on the face, on the trunk, on the extremities. Also had, along with this rash that had been going on over this like previous like 3 to 4 months, or 3 to 4 weeks, pardon me, had also had a little bit of malaise and felt like some swollen lymph nodes as well, and was just feeling kind of under the weather. And no past medical history that he was aware of, but he did endorse when we asked him high-risk unprotected sexual encounters with male partners. So this is the rash that we saw. These are just focal areas of the rash. It involved his face, as I mentioned, and all of his torso and his extremities as well. And he had these in areas erythematous, in some areas also scaly, overlying papules and plaques, and sometimes almost nodular lesions. And they were involving his palms and soles as well. We can advance to the next slide. And so based on this rash alone and based on his history, we were concerned about possible syphilis. And so we asked some clarifying questions, and he did endorse a history of a non-painful ulcer on his penis that had resolved approximately like 1 month prior to when we saw him. And so because we were in the derm clinic and this is part of the workup we could do, we performed a biopsy, and the biopsy was sent for H&E and also sent a direct immunofluorescence was performed on it. These aren't his actual slides, but these are representative images. So we're talking about syphilis, obviously. And I think that an important note histologically with syphilis is that similar to the cutaneous manifestations, the histologic manifestations can be mimickers of many different things. And so just not to belabor it, but the upper right-hand corner, it's a psoriasiform hyperplasia that kind of to an unpracticed eye, if you just saw this like lymphocytic infiltrate and you saw some neutrophil crusting and you saw that hyperplasia of the epidermis, you might think about something like psoriasis, which is something that syphilis can clinically mimic on the skin as well. And so you need astute pathologists like we have at USC. Our dermatopathologists are really excellent, and they would see something like this and right away hone in on spirochetes and then there's good staining that we can do. So the bottom image, the inside of that image is an example of direct immunofluorescence to T pallidum that can help to confirm a diagnosis of syphilis. So this gentleman had biopsies that confirmed his diagnosis, but also had spirochete specific and non-specific testing that also confirmed his diagnosis of syphilis as well. We can move on to the next slide. Again, please feel free to interrupt me. So these questions, no surprise to anyone who sees how technologically unsavvy I am, but they're not set up to have you answer them, but I just thought people could reflect on them. And there's just a few of them scattered in the talk. So this one is, which of the following is true regarding syphilis in 2021? So is it that A, rates have been decreasing in the US since 2000, B, neurosyphilis occurs 1 year after primary infection, C, rates of HIV co-infection are higher than the general population, or D, ocular syphilis only occurs shortly after infection? So I'll let you guys think about that just for 1 second, and then the answer will come up when Brandon, you can go ahead and advance the slide. It will show us the answer. So in this case, the best answer is C, that rates of HIV co-infection are higher in syphilis patients than in the general population. And we'll talk about that more a little bit coming up, and we can advance the slide. So syphilis, as everyone here is aware, is an infection with the spirochete T pallidum, and it can be mostly, since most of us here are seeing primarily adults, it's primarily, we see it is sexually transmitted, but can also be perinatally transmitted as well. And unfortunately, the incidence is in the US is on the rise in all age groups since the year 2000. And while it's on the rise in all age groups, we know that it also this rise has disproportionately affected Black men and Black women and Hispanic men as well. We also know, and I think it's important for us to know as clinicians, that the level of co-infection with HIV is much higher in patients who have a diagnosis of syphilis than it is in the general population. And we'll talk a little bit more about that in a second. Something that I read when I was preparing for this talk is that it made me feel like a little outdated and a little old, is that evidently the CDC, when it's using its pure terminology, is no longer really using the terms latent or tertiary syphilis, and that instead the terms for early, latent syphilis is usually early non-primary or non-secondary syphilis is my understanding. So my understanding is these are people that have no symptoms or signs of primary or secondary syphilis, but are believed to have acquired the infection like less than a year from the time of diagnosis, versus patients of unknown duration / late stage syphilis. And again, these are patients that don't have signs or symptoms of primary or secondary syphilis. And in this case, that we don't know when they acquired the infection, and that it may be over a year's period of time. So I don't know. I was telling my residents about this and they were like, that just seems confusing. And I agreed with them. But anyway, I guess the verbiage is changing a little bit. If we could advance. So this case, the patient was tested for HIV and was found to be HIV positive. And again, a note that the CDC does recommend HIV testing for all patients with syphilis diagnosis who are not known to be HIV positive. And this patient was neurologically asymptomatic. He saw someone in internal medicine, a review of systems, and neuro exam was performed. And because he was asymptomatic and no focal signs or symptoms, he had, there was no LP that was performed. He was treated with benzathine penicillin, 2.4 million units IM ×1. And a note here that HIV status does not affect the diagnostic or antibiotic treatment recommendations for syphilis, but may warrant closer clinical and serologic follow-up. And then the plan was for him to have clinical and serologic follow-up in 3 months. And the follow-up was going to be also with ID for management of his new diagnosis of HIV. And then in patients who are tested and not found to be HIV positive, so they're HIV negative, this is a good population to discuss pre-exposure prophylaxis with, because of their increased risk of acquisition based on data. We can go on to the next slide. So just me reflecting that I do feel like this documented increase in syphilis rates since 2000 is something that anecdotally I feel like that I've seen in clinical practice as well, both at county, CEC, inpatient, outpatient. We see a good amount of syphilis. And I feel like when I first started my training, I wasn't seeing quite the same amount. Again, this is anecdotal, but this is a patient here who we were seeing for several other issues in Derm, and got added on kind of urgently, and had this new onset rash that was more papular nodular on extensor surfaces, involved though the palms and soles. And she was adamantly denied like any high risk sexual exposures, has one partner that she had been in what she thought was a monogamous relationship with for 5 years. And but we felt like syphilis was like, we had a broad differential, but really felt it was syphilis. And sure enough, it was. So just a reminder, just to keep this at the forefront of your mind, and that the fact that it's so much more prevalent than it was a few decades ago. We can move on. And then just broadly thinking about cutaneous manifestations of HIV, so things that can prompt in the derm world, we do see periodically. I think as physicians, we're better at just generally screening for HIV, but certainly still people come into our clinics with skin changes that will prompt us to check HIV, and that we will usually a few times a year make a new diagnosis of HIV in our clinics related to these changes. And there's broad categories you can think of, and these can be inflammatory, infectious, neoplastic. So for inflammatory, patients with new diagnosis of HIV can present with just a morbilliform, kind of non-specific morbilliform rash. Patients can also present with new onset psoriasis or exacerbation of their psoriasis with a new diagnosis of HIV. And then they can, many patients with HIV have seborrheic dermatitis, just our fancy word for dandruff. So that can be something that, especially if it's quite pronounced or a new kind of rapid onset, can prompt us to test an HIV. And then along with a morbilliform rash, patients can be just xerotic and itchy, and pruritus, as a pruritus NOS like workup, can prompt a test for HIV. Infectious things that we think about, molluscum can prompt checking for HIV, especially things like giant molluscum, condyloma, Kaposi sarcoma certainly would prompt an HIV test. And then syphilis, but atypical presentations or typical presentations, either one, and recalcitrant HSV infections or other opportunistic infections, as you guys know, would prompt us, and then to test an HIV. And then also for neoplastic things, generally speaking, the increase of non-melanoma skin cancer is slightly higher in HIV positive patients. And so if patients especially present at a really young age with several NMSCs, or they present with like a atypically large NMSC, that could prompt us to test an HIV. We can move on to the next slide. So this is a second case here, and this is a 25-year-old female who presented with bruise-like lesions on her shins, and she had a diagnosis of Crohn's recently. And what you can see here is these kind of ill-defined erythematous to violaceous patches, a little bit of induration if you were to palpate them, and some tenderness to palpation as well. We can move on to the next slide. Thank you. So in this case, we're talking about erythema nodosum, which many of you have probably seen before. When we talk about this as a cutaneous manifestation of systemic disease, the first thing we think about usually is inflammatory bowel disease. So we think about Crohn's and ulcerative colitis, but EN is thought to happen a little bit more frequently with Crohn's than UC. And interestingly, the EN can either precede the diagnosis of IBD or can happen concurrently with it. And there's other associations though with erythema nodosum. So erythema nodosum is kind of like a neutrophilic reaction, and it's a paniculitis, technically speaking, an inflammation of the fat, and it's kind of a reactive state, and so it can be seen reactive to infection. So we can see it reactive to strep infections, reactive to histoplasmosis, various different infections, and then it can be seen triggered by medication. So several like common categories of medications. Some women have erythema nodosum triggered by OCPs, also can be triggered by sulfonamides. And then sarcoid can present with erythema nodosum. Generally, when patients have EN related to sarcoid, it's portends a better prognosis for sarcoid. Same thing goes, with infection. You can see it with cocci as well, and it portends a better prognosis with cocci if patients have associated EN. We can also see EN related to Behçet's. In my experience, limited experience with Behçet's, it can be a really difficult diagnosis to make. And I think it's helpful to know that if you see EN related to Behçet's, if you biopsy it, you can see like a vasculitis in the lesions of EN, which isn't typically seen in like run-of-the-mill EN. So that can also help to be a tip-off for the Behçet's diagnosis. We can move on. But there's many different associations with inflammatory bowel disease and skin. And so these are just a few of them. Brandon, I apologize. I'm going to have to ask you to click sequentially. So one is just oral aphthous. So usually aphthous ulcers, there's going to be an image that comes up if we forward click. Aphthous ulcers are common, as everyone here knows, and oftentimes not related to underlying inflammatory bowel disease, but especially if they're more pronounced, we can think about screening for IBD. And the picture will come up, Brandon, if we click for the aphthous ulcers. And then that's an example of aphthous. And then if we click again, Brandon, an example of pyoderma gangrenosum will come up. So PG is definitely like one of the banes of dermatologist existence because it's can be such a difficult diagnosis to make and a difficult diagnosis to treat. It's a diagnosis of exclusion when patients develop these neutrophilic based ulcers, and PG, like EN, can be associated with many different underlying things, and about a third of cases of PG are idiopathic. But one of the strong associations with PG is inflammatory bowel disease. And this is an example of a pyoderma gangrenosum lesion, which has this like gunmetal gray kind of undermined appearing border on the ulcer. But before we start blasting people with immunosuppression to treat PG, we have to rule out active infectious etiologies that can also mimic this clinically. And so it can be a little hard in that way. And then we can progress one more image forward if we could. And piostomatitis vegetans is kind of considered a variant of PG that can happen on the lips, generally speaking. And piostomatitis vegetans can happen in the context of IBD, but can also happen outside of that context as well, but can be recalcitrant to treat and very debilitating for patients. This is an example of a patient that I shared, I think, with one of our GI docs here at USC for a while. We can move on in the slide. So this case is an example of a 60-year-old male who complained of pruritus and diffuse bumps that he was noticing on both his legs, but also on his torso. On the torso of note, it involved like his shoulders and also involved his arms, involved his upper back and lower back, but kind of sparing in the areas where he couldn't reach. And he has a history of chronic kidney disease and has been on hemodialysis for about 2 years. So on physical exam here, you can see these like erythematous to violaceous nodules with overlying crust on them. And if you were to get closer, you could tell that they appear traumatized or excoriated. We can forward the slide. So this is an example of secondary change or prurigo nodularis related to end-stage renal disease-associated pruritus. So the most common cutaneous manifestation of end-stage renal disease is pruritus. I'm sure that probably everyone on this Zoom today has had a patient who suffers from pruritus, and probably everyone has had a patient who suffers from pruritus from end-stage renal disease. One thing I do try, just generally speaking, about pruritus to teach my residents is that it's just a miserable impact on quality of life for patients. And I think that as dermatologists, sometimes we're not taught to be empathetic about it because it's kind of can be a frustration and you feel kind of sometimes helpless with it because it can be very difficult to address. But certainly the quality of life impact on patients has been measured to be really significant. So it's something as physicians we want to pay attention to. The occurrence of renal pruritus is not associated of like renally induced pruritus or pruritus related to ESRD is not associated with gender, age, race, duration of dialysis, etiology of the renal failure. It's probably just related to the end stages of the renal disease. And the pathophysiology is unknown. I always tell my residents when we have massive lists like this, it means we don't really understand, but probably has to do with changes in the skin that relate to xerosis or dryness, may have to do with accumulation of toxic substances, elevation of parathyroid hormone and calcium phosphate products. There's a lot of things in motion that are thought to have some effect on it, but it's not that well understood. And we do know that most patients, the pruritus improves after renal transplant. So that's something that can help, but obviously is not an option for all patients. We can move on to the next slide. So end-stage renal disease associated pruritus, as far as like I said, I just touched briefly on treatment and some things, but just for people to be aware, and probably some people on the call know this, the treatment for this is multimodal. So it's not just one thing, it's not one size fits all. And we definitely start with doing good dry skin care, which it can include emollients and using mild soaps and things like that. I like light therapy in these patients. Narrowband UVB can help to control the kind of skin like immune activity that can happen. And then anti-itch topicals are helpful as well. Also low dose gabapentin is commonly instituted by nephrologists even before we see these patients, where they dose it like 100 milligrams after dialysis. We can advance. Thank you so much. So question, which of the following is not commonly identified as a cause of secondary pruritus? Meaning we think as dermatologists of primary pruritus related to a skin condition. So it's not eczema, it's not psoriasis, it's not scabies, but it's secondary pruritus on the skin secondary to something underlying. Which of these is not a commonly identified cause of this? Is it ESRD, CHF, cirrhosis, or Hodgkin's lymphoma? I like that people are getting bold and answering in the chat. That's great. We can forward it. Thank you. Thank you guys. I wish we were all in person together and you could like shout it out. I really love to lecture in person because it's just feels less and everybody's right. Excellent. So the answer is B, CHF. So there's many causes, but some of the heart, like high hitting things are end stage renal disease, cirrhosis. So both Hep C without cirrhosis can cause pruritus, but also cirrhosis of any etiology can lead to pruritus and very bad pruritus, as most of us are aware. And then Hodgkin's lymphoma is something we think about in the pruritus NOS workup. And the initial presentation of Hodgkin's can be with pruritus. Great job. Thank you guys. We can move on. So this is another case here, 70-year-old female who comes in complaining of pain in her mouth, has diagnosis of high blood pressure and CKD. And you look in her mouth and you see what we would describe as these like reticulated whitish patches on the buccal mucosa, some erosions as well. We can forward the slide. And in this case, I'm talking about lichen planus. This particular patient was found to be Hep C positive. The thing that the picture that I'm showing you of that mouth is like a picture, an example of like erosive oral lichen planus, which is thought to be more closely correlated to diagnosis of underlying Hep C, although many of these patients do not have a diagnosis of Hep C. In the studies, anywhere between 1 to 35% of patients, there's a broad range who are diagnosed with LP are found to have a coexisting diagnosis of Hep C, although we don't really know what to make of this kind of correlation. And my experience as a physician, I think that Hep C just is so pro-inflammatory to patients. There's really no end to the things that I've seen associated with it. And so I think that certainly to me, it's not that far-fetched to think that Hep C could be a driver in some of these patients. This on the right is a picture of like what many of us from like our step 1 boards think of with Hep C, which is those like purple polygonal plaques that are very itchy and more well demarcated than like eczema and more violaceous and less scaly than psoriasis. Hep C can be seen also, or excuse me, pardon me, LP can be seen also as a drug reaction. We can see lichenoid drug reactions are LP induced by medications. Some of the common things that we see are like ACE inhibitors, isoniazid, a lot of commonly used drugs, Plaquenil can cause lichenoid drug eruptions, but I put an asterisk here because recently a lot of the patients I've seen with lichenoid drug eruptions or LP induced by medications have been related to anti-PD-1 therapy, which is becoming, as everyone here knows, really like a staple of care for malignancies of all stripes. So that's definitely something that we can help with in dermatology, is helping to co-manage these patients who, if they're responding well to their immunotherapy, may benefit from other interventions to help to control these types of reactions. Contact allergens can also cause LP like reactions in the mouth as well. So in some of these patients who have bad oral erosive disease, we'll assess like for fillings and potentially remove them if they seem to be implicated. We can forward this slide. So there's a whole host of cutaneous manifestations of Hep C, and this is one of the many tables that will list some of them. We can move on to the next slide. And this is one of the ones where we have to forward it to show the pictures, but certainly with Hep C, we check Hep C status in patients who present with the small vessel vasculitis, like an LCV-like appearance, if we can click. So just this palpable purpura, that's one of the many things we consider as like a possible systemic thing to cause LCV. You can also see cryoglobulins. We can forward the slide. Cryoglobulins secondary to Hep C, and this can cause a lipidoid vasculopathy type appearance on the legs, which is more related to kind of an occlusion of the vessels rather than a true vasculitis. Go forward a slide. So, and pruritus, just there's no picture for the pruritus, but like I mentioned, Hep C without underlying cirrhosis can also be something that can drive pruritus, and then porphyria cutanea tarda can also be related to a hep C infection. And then we can see other changes like Terry's nails, which we call 2/3 nails, which is that white kind of line going down almost to the tip from the lunula, almost to the tip of the nails, and has to do with hypoalbuminemia. It can be seen related to hep C, but also just to liver failure in general. You can move on to the next slide. So this case 5, is a 55-year-old gentleman who came in complaining of dark spots on his shins specifically. He had a past history of type 2 diabetes, high blood pressure, and hyperlipidemia. And you could see on exam that you can appreciate these hyperpigmented, somewhat well demarcated like macules. Some of them look a little atrophic and indented on the shins. You can move forward a slide. This is an example of diabetic dermopathy that probably everyone here has seen. You may or may not have known what you're seeing when you see it. This is the most common cutaneous finding in diabetes. It's believed to be, and it's also believed that the frequency increases with age and duration of diabetes. It's thought that these are basically representations of extravasated red blood cells over time that leave a hemosiderin deposit and provides like a brownish hyperpigmentation. And this change correlates with coexisting macro and microvascular complications in diabetes. Interestingly, the blood flow in these is actually increased when it's studied. Dr. No studied that, I think, is like an internal medicine resident and also a dermatology resident, and found that contrary to what we would think, the blood flows increase. So these are actually thought to be a type of like aberrant scarring. And because of that, we think that they're precipitated by trauma. You can move forward. So another question. So acanthosis nigricans is another cutaneous manifestation of diabetes, and it can be appreciated. Is it A, in the axillary vault, B, on the posterior neck, C, on the inner thighs, or D, all of the above? We can advance, and the answer is all of the above. So good job, everybody who answered on the chat. Thank you. We can move forward. So AN is one of the other findings other than diabetic dermopathy that we can see in as a skin finding in patients with diabetes. Can we like click on the image for the image? Perfect. Thank you so much, Brandon. So here's another example of AN on the neck here, but it can be in all those locations and more. It can be on the dorsal hands. It can be even sometimes you can see it a little bit more diffusely in patients. We can move on to the next photo. So necrobiosis lipoidica is a less common, we used to call it NLD or necrobiosis lipoidica diabeticorum, but not all cases of NL occur in patients with diabetes, although I will say all the cases of NL I've seen have occurred in patients with diabetes. It's a kind of a granulomatous type inflammation that we see on biopsy and can occasionally ulcerate. It only happens in about 1% or less of diabetics, which is why we don't see it that frequently. It can ulcerate like this, or it can look more benign like the next image if we click forward. This is a patient I saw in my clinic who had NL at Keck in the last few years. And then there's another diagnosis, not that common, thankfully, but can be really recalcitrant and difficult to treat. We can forward, thank you so much, Brandon, which is scleroedema of Aldotorum of Buschke, which is a variant of scleroedema that occurs. It affects like the posterior neck up to the upper back. It's really indurated. If you advance, I'm not sure, is it not yet? Perfect. So this is kind of just, you can see that kind of like tawny, kind of hyperpigmented like look and a little bit of erythema to like the posterior neck, upper back. If you pinch that skin, it feels kind of like scleroderma to people. And it's reminiscent of that, but obviously the distribution compared to scleroderma is completely different. And the plaques are very ill-defined. Scleroedema does not only happen in the context of diabetes. It can very commonly happen after URI infection, like in young adult female populations as well. But this variant associated with type 2 diabetes can be really difficult to treat, but it's something we can see with diabetes. You can move forward in the presentation. So here's a sixth case here. This is like a little bit more of an outlier, but also in the endocrine family. And this is actually a case that Stratos and I saw together in the Room Derm clinic a few years ago, and was a little bit of like a exciting treatment success from a limited perspective. And so this gentleman is a 59-year-old male who had a history of Graves' disease. And his came into us, had actually come through, initially had been referred to plastics for evaluation of his lower extremities, kind of a wound care clinic that he was referred to. He'd had lymphoscintigraphy, he'd had Dopplers done for his veins, things like that, people assuming that these like changes on his lower extremities were related to either lymphatic or venous insufficiency, but those workups were essentially not revealing. And so finally, then he'd come to dermatology to be assessed. And he had a past medical history of Graves' disease. He'd had undergone thyroid ablation about 12 years prior, and he had type 1 diabetes and high blood pressure as well. You can see on the lower legs, he's had these, you can't appreciate how indurated they are, but you kind of, on that picture of the posterior calves, you can see how there's a little bit of a demarcation, like just below the popliteal fossa there, but had indurated, ill-defined plaques, hyperpigmentation, diviolaceous change, also had, you can see that infiltration. You can really appreciate on the dorsal, like ankle extending onto the dorsal foot, how thick that skin had become for him. And he had those little exophytic nodules, and ambulating was becoming difficult for him because he was just so infiltrated there and didn't have very good movement of his ankle. So he was referred to us for evaluation of these changes. We can forward the slide. He also had infiltration over the glabella, kind of what we would call leonine facies. His earlobes were more pronounced as well. And then he had restriction of the movement of his hands and probably what we would call like chiroarthropathy on his hands as well, and some thickening of the DIPs. We can forward the slide. So his TSH was 0.03, his free T4 was within normal limits, his chest x-ray was unremarkable, and he had some arthrotic changes of his fifth proximal interphalangeal joint, but his hand x-rays were not that exciting. We biopsied him, and the biopsy, you could appreciate a lot of mucin and dermal sclerosis on the biopsy. The lower image there is the colloidal iron stain. That blue stuff is highlighting the mucin in the dermis. So he had a lot of mucin. You can forward the slide. And for him, based on his histology, his clinical history, his cutaneous findings, we made a diagnosis of elephantiastic pretibial myxedema, which is just a really pronounced variant of pretibial myxedema in the setting of Diamond's triad. And Diamond's triad is something we don't see very often. It happens in less than 1% of patients with Graves' disease, but it's the triad of pretibial myxedema, exophthalmos, and thyroid acropathy. So that's what this gentleman had. This patient pictured below is another patient that we'd seen at County with a similar diagnosis at a different time. We can move forward. And so pretibial myxedema, not talking specifically about Diamond's triad, but just more broadly about pretibial myxedema. It's a finding that we see in most commonly associated with Graves' disease, but it's seen in less than 5% of patients with Graves' disease. And it classically presents as non-pitting edema. Usually it's just like small isolated patches on the pretibial surface, but there are rarer variants like elephantiastic, like our patient had, which is in less than 3% of patients with pretibial myxedema. You can also have plaque and nodular types as well. It can rarely affect the head and upper extremities as well. And so the pathophysiology is thought that the TSH receptor proteins that are found on normal dendritic fibroblasts are stimulated and then increase production of glycosaminoglycans. And there's other serum factors as well, most likely that incite fibroblasts to produce mucin 2 in these patients. And then the fibroblasts, it's thought the reason that it presents mostly on the shins, and who knows, but it's like one of the going ideas is that fibroblasts in the dermis of the lower extremities might be more sensitive to this for some reason. When things happen mostly on the shins, I always think it has to do with circulation, because certainly we know that the like robustness of the return venous circulation in these areas in all of us is not as good as the rest of our body. So that's kind of how I always explain those things to myself. We can move forward a slide. And there's non-specific findings in hyperthyroidism, and I'll start to go a little faster because I started later, and I apologize because my lecture I thought was short to start with, but I guess it worked out for my technical issues. But the skin for hyperthyroidism, non-specific things, you can have kind of like warm, moist, tacky skin. You can have associated diffuse alopecia, palmar erythema. You can get a concavity of the fingernails. Let's forward this slide, please. And then non-specific findings of hypothyroidism can include matarosis, which is thinning of the lateral part of the third of the eyebrow, and that skin, like kind of in the flip side, can be more cool and dry. And you can get a generalized myxedematous appearance with really severe hypothyroidism, which is just kind of like a waxy infiltrated look to the skin. You can move forward. So this is my second to last case. And oh, I'm so sorry. For this gentleman, this is one time when I again touch on therapeutics. So we tried some kind of basic therapies for him right off the bat, which was just topical steroids and compression stockings, and that was not doing the trick. And so then we did rituximab for him, and he got a gram of rituximab 2 weeks apart twice. And the reason, the thought behind this is that it has, as everyone here knows, anti-CD20 monoclonal antibody effects, and it targets B lymphocytes and halts their progression to plasma cells. And then the thought is that it decreases the TSH receptor antibodies and kind of the propagation or the kind of pro-inflammatory components of that for the fibroblasts. And the initial data from this actually came in Graves was it was utilized for thyroid associated ophthalmopathy, and it was found to incidentally help with severe pretibial myxedema. We can go forward. And this is a picture here, and if people can kind of hone in on those nodules have kind of melted away for him. This is after his first therapy with Rituxan, and about a month after his second infusion. And you can see he still has those creases on the dorsal ankle and dorsal foot, but much less pronounced. And it became easier for him to ambulate. So we definitely had some treatment success with this for a gentleman who was otherwise having a lot of struggles. Can move forward a slide. So here's my last case, and one of, that's very near and dear to my heart. So this patient, just kind of like an example patient, 50-year-old female who presented with itchy scalp and eyelids and a new onset of shortness of breath, and denied any past medical history. And you could see kind of these ill-defined erythematous, slightly eczematous appearing patches, upper and lower eyelids. Going forward. And in this case, the question is, you suspect a diagnosis of dermatomyositis, and a particularly high yield place to examine next would be, is it the ocular conjunctiva, the buccal mucosa, the dorsal hands, or plantar feet? Any thoughts? Move forward. And the answer to this is dorsal hands. We have a picture coming up next showing that. So looking at her dorsal hands, you could see something like this. This is a representative image, but some pronounced erythema over the interphalangeal joints on both the DIPs and the PIPs. And then also you can see that she has kind of ragged changes in the proximal nail folds, or colloquially the cuticles. And hard to appreciate on this image, but you can see a little bit of what is redness around those proximal nail folds. And that's what we call dilation and dropout of the proximal nail folds. We can go forward. So classic, just to review the classic cutaneous findings of dermatomyositis. So if you don't mind clicking through for me, Brandon. So the first thing, I like to highlight the paritic and erythematous scalp. And this can initially be confused for a lot of things, including sebderm, including allergic contact dermatitis, including psoriasis. But when it becomes helpful is that if you see what you suspect is a CTD or connective tissue disease patient, and you're trying to distinguish between lupus and dermato, lupus doesn't tend to have this erythematous itchy rash on the scalp. So that can be a tip off. Forward a slide, or forward a photo. Heliotrope sign, so it can be more subtle like that initial picture and look more like an eczema or contact derm, or it can be very pronounced with edema of the upper and lower lids. When that happens, we think it's related to underlying kind of edema and infiltration related to the myositis of the orbicularis oculi. Moving on. Poikiloderma is really important in dermato. So poikiloderma is the confluence of hypopigmentation, atrophy, and telangiectasia. And you can see this in some like named areas with dermato. So we can see it on like the shoulders, anterior chest, the shawl sign, or on the lateral thighs, what we call the Holter sign. And then thank you, Brandon. And then Gottrin sign is something that we can see on the elbows and knees. Again, one of the reasons this picture doesn't show how psoriasiform it can look, but it can look a lot like psoriasis and can be on those extensor surfaces. And again, make us kind of query or have people walk around with a diagnosis of psoriasis when they actually have dermatomyositis. And moving forward, Gottrin's papules, this is a pathognomonic thing. And those are those flat topped, sometimes almost like with a central dell looking papules that you can see over the interphalangeal joints and sometimes on the lateral digits as well. This is something I've seen confused for warts, all sorts of other things. So if you see something that looks kind of like that, but you're not sure, definitely investigate in other areas to see if you see anything else consistent with possible dermato. Next slide. Next picture. So also mechanics hands, which are not specific to dermato, but are kind of this like xerosis, fissuring, sometimes kind of tightening of the fingers that you can see. We can forward a slide. I think we have to click again. I'm sorry. So dermato, remember when you're considering a diagnosis of dermato, you have to think about two types of underlying disease. One is systemic illness and the other is malignancy, because dermato can be a paraneoplastic phenomenon. Moving forward. So remember with dermato, one of the things you think about is certainly muscular involvement. Now remember that dermatomyositis can exist sine myositis. It's probably about 1 out of every 5 patients. So certainly just because you see a rash that you think might be dermato, but a patient doesn't have any muscular symptoms, that does not preclude the diagnosis of dermatomyositis, confusingly, but in derm specifically, for obvious reasons, we see a lot of dermatocene myositis. You can use both clinical suspicion. So you ask them questions about proximal muscle weakness, see if they have tenderness to elicit this history. We also check labs. CK is the most specific, but we check things like aldolase and LFTs. If we have a clinical suspicion that's high, but those things have been normal, then the thing I see our rheumatologists jump most often to is ordering MRI of the muscles, but you can also order EMG, ultrasound biopsy of the muscles as well. And we have to also consider in these patients pulmonary involvement. It's probably, depending on the subtype of patient, somewhere between 50 and 30%. And to screen for this, we usually order CT scans, high-res CT pulmonary scans, depending on how worried we are, and then also PFTs. And cardiac involvement can be checked for with EKG. And then we order serologies and labs in these patients. And serologies can be non-specific, like ANA, which is elevated, not in all patients, but about 80% of them. And then we order now to a myositis panel or a which contains muscle-specific antibodies that are seen in polymyositis and dermatomyositis. And this can help us to hone our diagnosis, although there's definitely a serologic gap, and a negative myositis panel does not preclude the diagnosis of dermatomyositis. All right, moving forward. And then we have to worry about it again as a perineoplastic phenomenon. So just remember that the malignancy with dermato can be diagnosed prior to, simultaneously with, or after the diagnosis of dermatomyositis, which can be quite confusing, but means we just have to be vigilant. The risk for all comers with dermato is thought to be about 20 to 25% risk of underlying malignancy, so definitely not insignificant. In most series, it's documented that ovarian and colon CA are overrepresented, but a lot of series show that it's just kind of standard malignancies you would think in these age populations, which dermato tends to be bimodal. We tend to see the first peak initially like in childhood ranges, and then second peak is in more like the 50s. So the workup is really broad for this because it could be any underlying malignancy. So most of us do like chest CT, abdomen, pelvis. For women, order pelvic ultrasound, pap smear, breast exam. For men, also testicular and rectal exams. Usually we do colonoscopies and upper endoscopies as well. We don't order a lot of tumor markers anymore because, as you guys know, they can be quite confusing. And then the screening should take place annually for the first, depending on where you read and what resource you're using, 2 to 3 years. And at that time, if the screening has been negative, it's thought that the patient's risk should return to their age-adjusted risk. So then we just go back to age-appropriate malignancy screening. We can move forward a slide. And then I just wanted to give a quick shout out to those MSAs that were doing the myositis specific antibodies. One of them is MDA5, and I think this is a disease that I want all of us to know about. This is a subtype of dermatomyositis that's specifically associated with this MDA5 antibody. These patients have atypical cutaneous findings, so not all of them have classic dermato findings. Some of them have no skin findings, and some of them have just have both the typical ones and the atypical ones. The atypical ones are the painful erythematous palmar papules and also ulcerations. So these patients can present with spontaneous ulcerations on the dorsal hands, dorsal extremities. It can be quite pronounced and a lot of associated morbidity with them. But the reason it's really important that we recognize these patients is because they have a higher underlying association with rapidly progressive interstitial lung disease, which has a very high mortality if diagnosed, and they need to be treated and addressed rapidly. And it's a scary diagnosis to kind of work with because you worry about them a lot. We can move forward. I think I have 1 minute. Just the last slide I added was just talking about some other perineoplastic cutaneous findings. If we can go through these, just Brandon, click for me. So perineoplastic acanthosis nigricans. So it can be seen as like a really abrupt onset of AN that's not associated with insulin resistance or obesity or family history. And if you see it on just you can see it, so more classic locations like this, but then if you can advance a slide, something that's more atypical for like classic AN that we can see is something we call tripe palms. If you see just tripe palms, we really worry about underlying lung cancer, but if you see tripe palms plus the more classic AN, then we think about GI malignancies as well that can be underlying. And then we talk about the sign of lesser Trelot, which is just eruptive seborrheic keratoses that can be, we can forward an image, eruptive seborrheic keratoses. This is something I can say that I think that is often worried about more than its actual reality. But if patients present with eruptive SKs and underlying pruritus and xerosis, then I think that it's something that we should consider as underlying malignancy diagnosis. But most of the time, people just have a lot of seborrheic keratoses, and they've developed over time, and they have family members that have a lot as well. Then there's the diagnosis known as paraneoplastic pemphigus. We unfortunately, well, he's doing okay, knock on wood right now, but had a case of PNP that we've been managing at county. This is an exceedingly rare diagnosis, but is a variant of pemphigus that has lots of autoantibodies in the Plaken family, and notably from a clinical perspective has very robust involvement of the lips and buccal mucosa, which you can see in pemphigus vulgaris, but these patients have it kind of disproportionately to the effect on their body. And have an underlying association with several malignancies. It can be non-Hodgkin's lymphoma, CLL, Castleman's tumors, and we worry about them developing BOOP and dying from BOOP, bronchiolitis obliterans. And then the last thing I think picture for today is erythema gyrandum repens, which is this, we call it a wood grain type pattern. And patients have this rapidly migrating rash that's quite distinctive the way it looks. It's not always associated with underlying malignancy. It can be associated with a resolving inflammatory disorder, but definitely this should prompt a consideration of malignancy if diagnosed. We can forward a slide. So I think all my next slides, I won't go through them because in the interest of time, and I apologize again that I started late, but they're just one slide summaries that talk about kind of the highlight points from the cases that we discussed. So we're not missing anything by not going through them, but that's kind of it for new information for the talk. And thank you guys for your time and attention. And I'm sorry again for the technical difficulties, but it was nice to have a chance to talk with you all. And if anybody has questions.
I was just going to say thank you so much. If anybody has any questions, feel free to unmute, but I think there's something that we can all take away from this talk, inpatient, outpatient, across the board. It was great. Thanks, Ashley.
Yeah, it's my pleasure. And I'll stay on. I think my next patient's not for 8 minutes. And so
yes, and thank you for taking your time from your busy clinic day.
Oh yeah, no, it's my pleasure. I really like to do this, like I said. So thank you guys for inviting me and giving me the chance to come and talk. I hope everybody's having a good week. I can't believe that the holidays are coming up. It's kind of just mind-boggling to me.
Yeah, especially after we lost a whole year, it's hard to kind of recalibrate to what normal used to be.
Really hard. Yeah. Our stamina is down, and it's
and Zoom is constantly triggering anxiety.
Yeah. And I think it's emotionally just everybody's still recuperating everything. So
well, thanks to everybody in the audience, and have a happy Thanksgiving, everyone. Take care.
Bye. Thank you guys again for inviting me. Have a good day.
Brandon, thanks for your help.
Thanks, Brandon. It's nice